Okay, everybody, welcome to our bi-monthly uh, review of spinal cord injury topics. I guess this month is kind of a spinal cord injury adjacent topic, looking at critical illness, neuropathy, and myopathy, particularly what rehabilitation strategies can be used in considering these patients and how we can best serve them. We do see a lot of them on our inpatient unit following critical illness, following COVID, so it's definitely something we all need to feel comfortable addressing. So with that, I'll turn it over to Dr. Ben Silverman, who will be giving this month's lecture.
All right. So, hey, everybody. My name is Ben. I'm one of the new PGY2s here at PERM. I'll be talking about critical illness, neuropathy, and myopathy. Kind of the reason I chose this topic was actually the first patient I admitted here at PERM suffered from critical illness neuropathy. And I've never actually seen it in like the acute rehab setting. I've only seen it kind of last year when I was doing my ICU rotations. And kind of the pulmonologist and the ICU attendings would just kind of be like, this person's going to suffer from critical illness. But I never really got to see them kind of off the vent and really down the road. So I thought this was, a really interesting case. So I'm kind of just going to go through the case a little bit. We'll go over just kind of the overview of, what critical illness, neuropathy, and myopathy is. And then we'll go into like the rehab aspect of it, as well as a couple of studies. So the lady we had here, it was a 57-year-old lady. She had a history of HCV cirrhosis, hepatocellular carcinoma, diabetes, and hypertension. And she was admitted to HUP in May for liver transplantation. And then during her surgery, she had this portal vein bleed requiring massive transfusion. She had atrial fibrillation, AKI, and then a perfusion defect to the right lobe of the liver. Ultimately had to undergo a redo liver transplantation a few weeks later. And then this was further complicated by ventilator-dependent respiratory failure, acute renal failure, pneumonia, and asystole. So basically kind of throughout this prolonged like ICU stay and hospital stay, she suffered from acute renal failure. So she had dialysis, she had severe malnutrition. So her nutrition was kind of through TEN via Dobhoff. She had AFib requiring like amiodarone, and then eventually, she was on warfarin as well. And then she had a couple of episodes of like aspiration pneumonia, so she had a couple courses of antibiotics. She did have asystole, had to get CPR done. And then one of the things I noticed was that her glucose control was pretty poor kind of throughout this like 2-month hospitalization. And she had like sugars ranging pretty much between like 200 and 400 throughout like her acute care stay. So yeah, her hospital course lasted kind of from May until July. And then she was ultimately kind of stable to come to PERM like around like July 1st or something around there. So on her kind of original assessment, she had kind of brought up that her right foot was extremely weak compared to the rest of her body. She wasn't sure how this happened. She just kind of said that towards like the end of June, she just realized she wasn't really able to kind of move her right foot up or down. And there was no like inciting event or anything that would have caused it. So then on physical exam, just kind of her lower extremities. So bilaterally, her hip flexion was like a 3 out of 5. Knee extension was a little stronger. And then on the left, her ankle dorsiflexion and plantar flexion was like a 4 out of 5. But on the right, she was not able to move it at all, and just so 0 out of 5. And then she had some sensation as well that was kind of diminished over the dorsum of the right foot. So yeah, talking with like Dr. Abramoff, we were kind of wondering, why she would have this. I wasn't really familiar with critical illness neuropathy, so obviously we wanted to get like an MRI first, which just showed MRI of lumbar spine showed like this moderate to severe neuroforaminal narrowing at L3, L4, but mostly on the left. And then as well as some moderate bilateral foraminal narrowing at L5, S1. And these findings didn't really correlate with what we were seeing on her exam, as kind of this was showing the left side, and kind of the L5, S1 levels wouldn't really be causing this. So then she underwent an EMG with Dr. Dillingham, and the EMG showed findings suggestive of motor and sensory primary axonal polyneuropathy affecting the legs, which was consistent with critical illness polyneuropathy, with the right lower limb being more involved. It had no evidence of myopathy. So kind of the overview, kind of what is it and what happens. So critical illness neuropathy and myopathy, they're kind of very similar. They can happen together or independent. So there are frequent complications of these severely ill patients, and it involves like the sensory motor axons as well as the skeletal muscle. So in critical illness neuropathy, you basically get this axonal degeneration of the sensory and motor nerves. And then in critical illness myopathy, you get this loss of myosin in the muscle tissue, you get atrophy, as well as like degeneration of the muscle fibers. So kind of going into the epidemiology, so incidence very obviously specific to like the underlying disease process, the diagnostic criteria being used, and as well as like timing of evaluation. So if someone's kind of diagnosing this early on versus later on in acute rehab, it can definitely differ. And then I thought these percentages were kind of interesting. So if you had one of these kind of disease processes going into the ICU, this was kind of your percent chance of actually developing CIP or CIM. So for ARDS or acute respiratory distress syndrome, there was about a 60% chance of actually developing it. Sepsis would be 70% chance, and then sepsis leading to multi-organ failure was almost like around 100%. And then another stat that I found interesting was that in patients who received mechanical ventilation for at least 4 to 7 days, the occurrence of CIM or CIP was 30% on clinical exam and up to 70% on electrodiagnostic testing. So what are the risk factors? So big ones are like sepsis, severe inflammatory states, multi-organ failure, ARDS, prolonged ICU stay, prolonged immobilization, hyperglycemia, prolonged use of neuromuscular blocking agents, and obviously the longer you're kind of paralyzed, you're going to be immobilized as well. And then kind of specific to critical illness myopathy was this high and prolonged dose of steroids. And kind of looking through these, kind of the patient that, we had here, kind of, so she had multi-organ failure, she had respiratory failure, renal failure. Her hospital stay was around 2 months. And then looking at the risk factors, I noticed hyperglycemia was one of them. So I actually went back and kind of looked through her chart, and I noticed that her sugars were very poorly controlled kind of throughout her stay. So pathophys, not fully understood, thought to be multifactorial from a bunch of different things. So there's like microvascular alterations. So you get kind of edema, increased vascular permeability, capillary leakage, and kind of just leading to hypoxemia. You have like metabolic alterations. So big thing was the hyperglycemia, which can kind of damage the blood vessels that supply the nerves, as well as like hormone changes. And then you have electrical changes, so ion channel dysfunctions, and prolonged electrical like depolarization of the cells. And then also just like increase in reactive oxygen species, mitochondrial damage. So kind of all these things can lead to, damage of the axon as well as the skeletal muscle. So features, so some similarities. So for neuropathy, you're going to have this flaccid weakness, usually distal more than proximal. You're going to have loss of pain, temperature, vibration. And then more in myopathy, you're going to have more proximal than distal weakness, as well as some muscle atrophy. And then kind of in both of them, you'll see like decreased reflexes, maybe absent as well as like failed attempts at weaning from mechanical ventilation. So a lot of these patients that are kind of being trialed off the vent in the ICU, and they're having difficult time kind of weaning them. One of the things to think about is definitely critical illness neuropathy or myopathy, just given the diaphragm, the nerves innervating the diaphragm can definitely be affected. So screening evaluation. So you can screen for this with like the MRC. So test that scores these muscles on 0 to 5, evaluates to 12 total muscles. The big movement: shoulder abduction, elbow flexion, wrist extension, hip flexion, knee extension, ankle dorsiflexion. So it ranges from 0 to 60, and a score of less than 48 suggests critical weakness. But these limitations are high. Requires full cooperation of the patient. So the earlier you do this, if they're in the ICU and they're more sedated, it can definitely differ from testing this later on. And then kind of getting into the diagnostic tests. So nerve conduction studies and EMG. A couple things you'll see are reduced compound muscle and sensory nerve action potential amplitudes. You'll see some positive sharp waves and fibrillation potentials in these resting muscles. But one thing to note is just for the conduction velocity, it's usually normal. And this is important just because another diagnosis that's pretty high up on the differential is Guillain-Barré syndrome. which would have kind of this reduced conduction velocity because it's affecting the myelin rather than the axon. But in critical illness neuropathy, you're just only kind of damaging the axon, so your velocity will be normal. And then up to note as well, so it usually takes about 2 to 3 weeks for these changes to actually show up on EMG. So you don't want to be getting one, while they're in the ICU, like immediately. You want to kind of wait till the acute period is over. And then you can get a muscle biopsy as well, just showing some like fiber atrophy and denervation within like the small muscle fibers. There are some biomarkers, specifically like CK, which people look at, but it's usually normal in like critical illness polyneuropathy because it really only comes up if there's like muscle necrosis. So we don't really rely on those. And then kind of getting into the management, treatment, prevention. So it's shown that intensive like insulin therapy has shown to significantly reduce CIP and CIM rates, reduces the duration of your ICU stay, as well as your 6-month mortality rate. Also nutritional optimization, so omega-3 fatty acids, amino acids, obviously enhancing kind of just skeletal muscle buildup. And then early treatment of sepsis, definitely don't want to delay like antibiotics or anything like that. Can definitely worsen the neuropathy. And then obviously most importantly is rehabilitation. So big things, early mobilization, range of motion, whether it be passive or active, strengthening, splinting, bracing, electrical stimulation, and frequent repositioning. And then kind of why do we do these things? So mobilization, we want to prevent, DVTs, venous stasis, range of motion, preventing contractures. Strengthening, we want to preserve, obviously, the muscle anabolic activity and prevent atrophy. And then splinting bracing is important as well. Just if, we want to support these peripheral joints in comfortable and functional positions during, these kind of periods of paralysis. And then repositioning as well to prevent, these decubitus ulcers. And it's really important that we, take all of these into consideration because just one minor setback can really cause a lot of issues down the road. So a couple studies that I was looking at, one had to deal with early therapy. So this was a randomized control trial, looked at about 100 patients who had been on mechanical ventilation for less than 72 hours. And it evaluated the use of early rehab in the ICU. So one group was the group that had specifically early exercise and mobilization combined with daily interruption of sedation versus just the control group, which was daily interruption of sedation alone and no therapy. So patients in the therapy group had PT-OT initiated early. So this was like 1.5 days versus 7.5 days after intubation. And so the patients in this intervention group were shown to have more ventilator-free days, so 23.5 versus 21. Greater proportion of patients had a return to their kind of independent functional status at discharge, and that was about 59 versus 35%. And then shorter duration of delirium as well, so 2 days versus 4 days. And then another study I thought was interesting was the use of electrical stimulation in these patients. So this smaller study, but it looked at about 50 patients that were critically ill in the ICU with this Apache 2 scores of greater than 13, basically just an ICU scoring system of how kind of severely ill somebody is. So they had 24 in this electrical stimulation group and 28 in the control group, which they didn't receive anything. So they basically got 55 minutes daily of bilateral lower extremity E-stim, specifically to the quadricep muscles until the end of their ICU stay, which averaged about 14 days. And then it showed that there was a decreased rate of like examination defined CIP-NM, so 12.5% versus almost like 40%, decreased weaning time 1 day versus 3 days, and improved motor examinator scores, so 55 versus 52. And then it just showed that like 3 patients in the E-stim group versus 11 patients in the control group were kind of diagnosed with critical illness neuropathy, myopathy based on the MRC score of less than 48 we spoke about a little earlier. So as far as prognosis, so very variable. Most patients will, remain pretty weak at discharge, but it can gradually recover over time. Obviously, it can be in the mild cases, it can kind of recover faster, maybe in weeks, more months to years in severe cases. But, some patients, they might not recover at all or just kind of be functionally impaired for quite some time. And then there was another thing that I looked at that really, there's not really any evidence, but it's just been shown that critical illness myopathy have this like better prognosis versus critical illness polyneuropathy, but very like unclear at the moment. So kind of just finishing up on her case. So she stayed a total of 24 days here at Perm. At time of discharge, she had this custom dorsiflexion assist ankle foot orthosis, which she was like using to walk around. So just kind of comparing her exams side by side. So she had obviously the zeros in dorsiflexion and plantar flexion when she got here. And when she was leaving, her dorsiflexion on the right was about a 1, and plantar flexion was a 2. So obviously, it's not 5 out of 5, but it's definitely progress. And she's obviously going to continue to do outpatient therapy as well. So yeah, big picture. I think just having everyone, whether it be a therapist, nurses, doctors, social workers, CNAs, psychologists, dietitians, everyone kind of working together from this like early period in the ICU all the way through the end of acute rehab. Because the prevention and the diagnosis, it's all dependent on different things, antibiotics, like nutrition, therapy. So everyone, plays a role. And I think, if everyone does their part, we can definitely reduce like the time it will take for someone to kind of recover from one of these illnesses. And that is it. Does anybody have any like comments, questions? Okay, whoops.
Carol here. I just noticed on your particular case, her medical research council score would be pretty high for starting. And I've often noticed in many of our critical illness myopathy cases, and of late our COVID patients, their initial scores are probably closer to maybe 6. And nowhere near the score of your patients. So I could see where that probably has a big impact on their outcome. The 10 study was interesting because many of the units that we have to use are very underpowered. So the time to spend to stimulate one muscle when it's a whole body effect is kind of interesting that they had something positive come out of that when it's hard to stimulate the whole body.
Yeah. A lot of like when I was like kind of looking through studies, I saw they were doing a lot of studies actually on this electrical stimulation on patients. But yeah, I can see how it could be kind of like a harder process to do.
Thank you.
Any other questions? Thoughts? Well, thanks, Ben. I think that was a really great overview of a topic that we see quite a bit. And I think it's pretty clear that, we still need to kind of develop good evidence for what interventions will tend to help these patients, particularly in the kind of the acute rehab phase, which is a little bit different than kind of the preventative early phases. And so I'd be interested to see what research comes out in that area.
Yeah, definitely.
All right. Thank you, guys.
All right. Thank you.